So for the next presentation, can I invite Dr. Amit Joshi from Nepal? And he has been showing wonderful cases in all our previous meetings. And I'm sure that today also we'll get to see some different case.
Thank you, everyone. Thank you, Team Master Case Series, for inviting me, 5th time in a row. But this time it's a very, very simple case. You know, after Pradeep's case, I'm a little hesitant to present my case. This was a 27-year-old young lady, sustained road traffic accident about 12 months ago, and had a right-sided patellar tendon rupture with a small chip of inferior pole of patella fracture. She underwent patellar tendon repair. So this was the surgery. It was done, about 14 months ago from now. This is the one. So if you can see, the inferior pole of the patella was fractured. They have not mentioned it was done abroad, so they have not mentioned what was done. But actually, this is the picture she has kept, not of the very good quality. But this is how the surgery was done. So to the panelists, what is your recommendation to use Circula's wire for augmentation of any patellar tendon repair? Deepak sir, what do you think about this?
I'm not very great educator. Okay.
Not very much, okay. So may I know the show of hands for this type of surgery? Anyone in this hall do that? None of these, okay. But this is how she presented. So first ARS, if you have to augment, probably you said that wire, SS wire is not good one. So if you have to augment, what is your preferred augmentation technique? Autografts, allografts, synthetic, or fiber tapes? So autograph. So Deepak sir, you also choose autograph, right? So why you think that this wire is not good enough?
Because it is amenable to the stress riser effect. If the healing is not taking place and patient's own tissues are not taking a back, then it will break very soon. And autograft gets integrated very nicely with patient's tendon, and I get very good results with autograft.
Absolutely, absolutely. She comes to us, not to me, she comes to one of my friend, orthopedic surgeon, with, that X-ray, and with the range of motion is just 0 to 40 degrees. This was the range of motion. Her primary concern was range of motion. She was not able to do her work, just 40 degree of arc of motion. So the second one is how to achieve now, how to advise, or what are the ways by which we can get a range of motion for this patient. Can we have a second ARS, please? Okay, arthroscopic arthrolysis is the major one. Okay, perfect. So probably she went to general orthopedic surgeon. That's why the surgeon actually did all the investigations, MRI, and planned actually implant removal and manipulation under anesthesia. But as you all know that manipulation under anesthesia failed, he just removed the, the wires that was there. And this is how the patient presents to us after 9 months of injury and the 2 surgery undergone. And this is how the patient present to us. And her only one requirement was she want her range of motion as much as possible. And if you can see the previous and this one, almost similar range of motion, 0 to 40 degree. There was not. If you can see that extension was perfect, yes. No lag also.
But there is a significant patella baha.
Yeah.
Yes. So what will be the next option for this patient? Now she is with us after 9 months of index surgery. So how to try to achieve, reasonable range of motion in this case? So again, open arthrolysis with quadriceps plasty or whatever you want, please.
Yes.
So open arthrolysis.
I think that open arthrolysis is a good choice, but the problem now is also the length of patellar tendon. If you do a tibial tuberosity osteotomy, is okay, but I am very afraid. So if I begin this kind of surgery, I prefer to have in operating theater also a cadaver allograft with a quadricep tendon, patella, and patellar tendon.
I'll also like to add what quadruplasty will do here, because quadriceps is not the problem here. The patellar tendon is shortened, right? The cerclage wire which was done or the patellar tendon which was sutured, it's led to the contracture of the patellar tendon. The patellar tendon is the problem. So anything in quadriceps is innocent, why bother it? What you want to need is to explore the patellar tendon, see what is wrong, or study on MRI. If there is a contracture, probably you need a patellar tendon plasty, or release the contracture, and if you can make it this thing, provided patellar tendon is healed.
No, you can bring a patella alta down, but in a patella baha, what can you do?
No, but if there is patellar tendon contractures, you might have to release it. If it is not releasable, you can do the lengthening of patellar tendon if it has healed well. Yes. You can also do tibial tuberosity osteotomy. There is nothing wrong in that. But first thing is we need to identify where the pathology lies.
Yes, Shekhar, if it has healed, as Deepak said, you can lengthen it by Z-plasty or by tendon augmentation. And if it is less than that, then you can also do a tibial tubercle transfer proximally to less than that. These are the options.
But there's a chance that if you do proximal migration of tibial tuberosity, she may develop extensor lag.
Not for this much. I would rather think of, if I have to, if the patellar tendon has healed, strictly consider Z-plasty lengthening of the patellar tendon.
I think, let me add to some, I didn't put the literature out here because just wanted to show the case. Literature says that if there is a patella baha, the problem is not in the quadriceps. It is inferior to the patella. Yeah. It has to be inferior. And if you see the X-ray, there is a clear-cut patella baha in this case. So either then to engage or to manage this, you have to lengthen the patellar tendon, either in the soft tissue or in the bony. So that is the what. Okay? So that is what we decided. Patella baha was the key one. So just by doing quadriceps plasty, you are not going to gain too much of motion. Even if you gain range of motion by doing something up, it's going to be patellofemoral severe pain, and the patellofemoral arthrosis is going to set down.
You're totally right. Thing is that what I want to press is that it's easier to manage patella alta, and it's very difficult to manage this patella baha.
So that's why the case is here, and this is just the start. It is not the finish. It is just the start. So we decided that we'll go ahead and then inspect, as Deepak sir said. If you see the MRI that I skipped, if you see the MRI, there is not much, there is a contracture and there is a bony formation. You see that the bone formation in the patellar tendon, the upper pole of the patellar tendon. So we decided that we'll not do anything with the patellar tendon because it's going to be difficult for us. So we decided that we'll proximalize we'll do a tibial tubercle osteotomy and proximalize. And just, after cutting the tibial tubercle osteotomy, you could see that without any pressure, we could achieve nearly full range of motion of this particular patient. But this was the start of the problem, not the end. This is how we fixed it. And then it was post-operative period was uneventful. And then she comes to us after 3 months. You can see the scars and very good patella. Now patella is mobile, not in the medial lateral direction, but also in the superior inferior direction as well. And the most importantly, she was gaining range of motion about 120 degree. So I'll just show you how much was the range of motion. So about 120, 125 range of motion. The patient was very, very happy, after this surgery. And then she disappears for some time. And she gives me a call saying that some doctor has advised for resurgery of this thing, And then she started feeling some crepitation around the anterior part of the knee. And this is how she presented to us, The whole tibial tubercle osteotomy has flown off. It has completely gone off. You can see that it is completely. And then the calcification that was happening in the proximal part of the patellar tendon is extending below, So practically there is no patellar tendon based upon the X-ray. It's the tibial tubercle and the inferior pole of the patella, you can see there.
Dr. Amit, what was the power?
Sorry?
There was no quadriceps lag. The power was okay?
I'll come to that.
Okay.
First, let's see what the audience has to say. What next after this one? Refixation, or patellar tendon reconstruction.
The MRI and the clinical findings.
MRI I didn't do, but clinical findings I'll show you. Absolutely. That is what we thought, that probably in this case, patellar tendon reconstruction would be a better one, but we went through the clinical examination, and this is the clinical examination. You can see that she was having a small, bony prominence there, the tibial tubercle osteotomy. She was having the screw head. It was not that much palpable. If you see that she's a little bulky one, it was not palpable. But what is important is the range of motion. I'll just show you that how much range of motion. This is absolutely 125-30 degree of knee range of motion at about 9 months. I'll show you, someone was asking me how about the extension lag. So there was no extension lag, and yeah, that was the X-ray at that point. Yes, this is the X-ray. So, and then she was not having any problem, except some doctor has seen the X-ray and said that your fixation has completely blown off. Except that she was not having any problem. So, would you still do anything, Deepak sir, now with this?
So we treat patients, not the X-rays. Definitely, there's definitely lots of things which has gone wrong there, but the luck is on your side. There are probably soft tissue contractures and retinaculum contractures which is keeping the extension mechanism intact, even though the tuberosity has migrated upwards. Or maybe when you do tibial tuberosity, there is some part of patellar tendon which is still attached to tibial tuberosity and which is giving her that much good extension. The patient is not complaining. The supervised neglect can be an option. I don't mind doing that. And don't take X-rays again.
So we chose this supervised neglect since the profession was not very good. She was a beauty parlor assistant, so she was managing.
What can be the reason of failure of this fixation?
Maybe because the patellar tendon was not sufficiently, lengthened. The patellar tendon was contracted, so it just pulled off. When we started aggressive knee range of motion, because that was the aim of achievement, aim was to achieve knee range of motion. Because of aggressiveness, it just went on. I'll just show you some of the videos. I'll not go into this one, but look at the power. Her power, just 1 year follow-up. She was doing absolutely everything. Her power on both the side almost equal, she was doing her activity of daily living, and then her flexion is also improved. Now it has reached up to 130 degrees. So she is not having any complaints at this moment. Although I suggested that I might just need to remove the screws, whose head is just, poking out. We need to remove that screw, but she denied. I had undergone 3 surgery because of this thing. I don't want any surgery unless there is a serious problem. So, few take-home messages I took. The knee is very prone for stiffness, so our fixation method should be strong enough to allow early range of motion. If the first surgery would have done better, probably augmentation required, autograft augmentation, and the aggressive rehabilitation would have avoided all these complications till date. Second one is understanding the cause of stiffness is very, very important. Just removing the implant and trying to do a MUA wouldn't have helped this patient at all. And finally, the most important take-home message for me was treat the patient, not the X-ray. Thank you very much. Thank you.
Yes, please.
That was an excellent case and also a good follow till the end, and also to show that you should not treat the X-rays of the patient. I think the tibial tuberosity fragment got resolved over a period of time, but it remained attached to the tibia. And this thing was the calcification inside the patellar tendon. Sometimes it happens like that.
No, sir, the screw holes are seen in that fragment. If you look at the X-ray carefully, the screw holes are seen.
Can you see it again?
Yeah, it is there. The screw holes in the fragments are there. It has blown up. Yes.
It has vertically probably split and then gone up.
Yeah. And when you clinically examine, you'll feel that the tibial tubercle is moving, all around. So it was non-union.
So much of nice fibrosis which has
absolutely
taken the function of the extensor mechanism.
Amit, the only thing I could have done differently was to explore the patellar tendon, put a nice incision, identify the patellar tendon, where the contracture is, release all the contracture, and then decide what should be done. Because here the culprit is contracture of patellar tendon. In one of my cases, there was a Hoffa's fat pad contracture, which led to patella baha. And as soon as I arthroscopically released the Hoffa's fat pad contracture, the lengthening.
I think that is what we did. We opened the joint, removed the Hoffa's fat pad and tried to flex it, but it was not possible.
possible.
But I didn't do thorough exploration and then didn't try to lengthen the patellar tendon. I went with the lengthening of the extensor mechanism through the tibial tubercle osteotomy.
Thank you.
Thank you very much. Thank you.